This is a quick intro to the Sonosite and how to start peripheral IVs using the ultrasound machine. It's a great way to get them when nobody else can get access. The Sonosite S-Nerve is what we have down in the operative suite. The on button's right here. Just a few things you need to know to get the machine up and running. Just hit that button, it comes up. It is battery operated. The battery is right back here, and like any piece of electronics, taking this out does reboot it pretty good. It's just a pull down here at the top. It does not need to be plugged in to be used at the bedside, so you can keep it mobile and not get the wires in people's ways, but it will need to be plugged in from time to time or it loses its charge, and the OR crew is extremely unhappy with us. Once you get it up and running, there's a few things you should know. When the OR crew likes to use it, they tend to leave patient information up here in the upper left corner. If you just hit the patient button, which is right here, it'll bring up the last patient's information. You can go ahead and clear that just hitting this right here, which corresponds to new end. It wipes all that info, and then over here is done. Get you back into your ultrasound mode. We have two probes on our ultrasound machine. The big one is great for deep imaging, things like a fast exam looking for blood and trauma, things like a cardiac echo looking at the bladder, for example. It's not what you're going to need for superficial stuff. This little one here is a much higher resolution. As a result, it can't penetrate very far into the body, but it can differentiate small things, so it's better for you for looking at little blood vessels and that sort of thing. Each one of these is connected to a metal plate like this, and on the back of the Sonosite you will see that metal plate goes in right here. Right now you can tell from the shape on the screen, this round thing, that we've got the wrong probe connected, because the shape on this one's round. So you go to the back here, you take this little metal clip, pop it up, twist it, and this little plate just pops off. There's a spot in the back of the machine where we like to tuck those plates to keep them from getting wet or getting injured. And then you put the other plate on. Just the reverse process. Snap it on, twist it, lock it, and in just a minute it's good to go. Alright, now we got the straight across bar. You can tell we're using the good one for ultrasounds. On the probe, you've got a little notch on one side. The other side is kind of smooth. That notch corresponds to this green dot on the screen. So, if you're ultrasounding somebody in a bed, and you keep the notch on this side of their body, you'll always have this side of the screen corresponding to the left side of the probe. That's great for when you need to maneuver an IV needle. You see you're just a teeny bit far off to the right, you want to know which direction to go to get it in. In terms of keeping these clean, the OR crew cleans with 70% alcohol, and that's great. In the back of the Sonosite, we actually keep tegaderms. These tegaderms make for a perfect sterile cover. All you have to do is pull one out and slap it on top of the sucker. Just make sure you don't leave any air bubbles, because air is kryptonite to ultrasound, and you'll get little lines on your screen you can't see through. So, with the tegaderm on, you're ready to go. You need some gel on top of this thing. Ultrasound gel allows you to always contact the body. It doesn't leave any variations. You'll want more gel if you're going for a very rounded structure, just to apply contact on the sides. You don't need as much for a very flat structure. And then you can do your ultrasound. If you look on the screen here at this very side, you see that 2.7? That's the depth in centimeters that the screen is visualizing right now. So if I have this ultrasound probe up here, and I'm ultrasounding somebody's arm, and I see a blood vessel on the screen, say right here, I know that it's about 2.5 centimeters deep, just using those dots on the side. You can change that depth using this knob right here, the depth knob. About 2.7 will usually be pretty good. You don't need to see distance, you don't need to see further. You can take it all the way up until you see, say, 6 centimeters, but you're never going to be putting an IV in quite that deep. And you can go more peripheral if you just want some very fine resolution, but usually that 2.7 is pretty good. We have our normal IV needles. These catheters are about 1¼ inches, so what is that, 32 millimeters. So be very careful. This catheter is truly about as deep as the vein is if it's down near the bottom of the screen. That means you can't really use these for deep veins. You go all the way straight down, it would have to make a right angle to get into the vein, and there's no way you're going to be able to infuse through that even if you manage to thread it somehow. So, in the back of the cart we also keep bigger ones. These are all 18 gauges, but they are 64 millimeters. So if you find a deep vein on somebody down here in the screen, a great way to be able to cannulate it is to use a bigger IV. You come in, a longer IV I should say, come in from the side, 45 degree or 30 degree angle is best. And then when you make it to the vein, go ahead and thread, advance the catheter just like you normally would, and it allows a good portion of the catheter to be in that vein, sort of like a mini PICC line, and that gets you closer to your target. If you just heard that sound, that dee-dee-dee-dee, when the machine is getting ready to shut down because it hasn't been used for a while or because the battery is dead, it makes that sound. It gives you a little warning that it might be time to plug it in or your screen's just going to go black. Another thing you should know is if you don't use the machine for about 5 minutes, it will shut off on its own. That's really inconvenient at times when you're putting in an IV without an assistant. If you're messing around for 5 minutes, you lose the screen. You have to get back up, hit the power button again to start over. In terms of where to look and what things look like, threading an ultrasound is no different than when you do it by hand. When you're looking with the ultrasound, you're looking for a couple things on the screen. Keep that notch on that side. I'm going to put it on me here, so just right there. And we're going to scan up and down and look for veins. You can see right at the very top center of the screen, there's a little black dot right there. That is my big vein, my antecubital vein. One of the highlights of veins is they're easily compressible. I can push down and that sucker goes away. Let off and it opens back up again. Arteries tend to do the opposite. When you hit an artery, it tends to pulsate because it's got high pressure going under it. Let's see if I can find one up here in my biceps. When I try to crush that, see that circle right there? It doesn't crush at all, and when I give it a lot of pressure, it starts throbbing. If you see that, it's bouncing up and down. You should be careful if you have people that are hypotensive, the people we really need to get an IV into. If their blood pressure is significantly low, they might not have that incompressibility factor that most arteries have. So just be sure that if you've got somebody with really low blood pressure, you check to be sure it's a vein. So, when it comes to vein selection, you've got a number of veins in the arm. You want to stay away from the one that runs right next to the artery. That's the deep brachial vein. Because it's so close to the artery, when they're side by side, we don't want people in general poking needles around there, at least until you're extremely experienced, and so we're considering outside the nursing scope at this time. What you would do on this, because this is so close to the surface, is simply line it up so that my arm and the transducer puts the black dot in the center of the screen. When it does that, you can put the needle in right in the middle of the transducer there, and you're going in at approximately the level of that vein. One thing to watch out for, especially in people that have had a lot of procedures and blown a lot of veins, is sometimes the veins disappear as you go upstream. They might be clotted off and solid and incompressible. They might turn at right angles, and when you go by feel, of course, you always feel upstream to see where that vein is going. When you're doing it by ultrasound, you just move the ultrasound up the arm and make sure that the direction you think the vein is going is the direction it is going. I usually try to pan up and down a few times until I have a very good sense of where that vein is. In this case, it actually there we go. Now you can see this vein in the upper center as I come down stays near the center of the screen. So it's at this angle along my arm, and I'd want to go upward like that to get a good IV start on that particular vein. You secure it just like any other procedure. Do be careful as well. If you put an IV in that's pretty deep on a patient a couple centimeters under, there's a lot more space in the deep tissues for that vein to release fluid. So if you weren't quite in the vein, or if the cannula comes out of the vein, you can dump a lot more fluid in than you can with something superficial before you realize it's going in the wrong place. The most critical time would be CAT scan. Whenever I'm using a deep vein, I like to check and make sure that it draws back and flushes really easily right before the contrast injection, because you can dump about half a bolus of contrast into an arm before you realize that it's going into the tissues and not into the vein itself, and then the patient has to be admitted for warm compresses and that sort of thing. So just be sure those are still patent whenever you're doing some caustic medication. Just a little extra teaching about what you can find in the arm so you know what your other structures are. Arteries and veins are black circles. If you turn them sideways, you can catch them lengthwise. So if you see a long black tube, that would be the vein running lengthwise. That's the black lines across the top of my screen. If you look down at the bottom, you can see how most of this from here over and up is gray. That's actually a muscle bundle. That's one of my forearm muscles there. You generally don't want to go through a muscle just because it's kind of painful, if you can help it. Muscles are covered by adipose tissue, just a little fat, and fat is very reflective. So any gray-shaped structure covered by a very discrete fat white cover is probably muscular. As you get further down in the body, if you get low enough, you'll see bone. Bone is another thing that ultrasound just can't penetrate, and so you'll see a really white focus, like that white circular thing at the bottom of the screen right there. And past that, if you're going any deeper, you'll get no echoes whatsoever. It just looks black because the ultrasound just can't penetrate down there. You get nothing past it. That's a bone. Try to stay away from those as well because they're incredibly painful. To complete the rest of this mini training, you're supposed to do 3 proctored sticks just so we can answer questions and you can practice moving left and right. It's got a lot of Nintendo skills here. If you're good at moving one hand up and down and the other poking, you'll do this very well. In the anesthesia office, they have a little phantom. It's a little purple toy disc, I guess you'd call it, where you can stick the needle in and watch yourself do this under ultrasound without practicing on a real person. And I'm happy to get that out anytime if we're working together. Alternatively, if you want to try it on a patient, let me know and I'll be there and we can do it. Thank you.